Hi, and welcome to OneMedicine. Today we'll talk about drug-induced generalized exfoliative dermatitis. It is also called as drug-induced erythroderma. Exfoliative dermatitis also can be called as erythroderma, which basically involves that there is erythema and scaling, which involves more than 90% of the body surface area. So, this drug induced erythroderma will be an adverse drug reaction which is characterized by erythema and scaling, that is redness, and there'll be scales present which will affect more than 90% of the body surface area. So, that's very important in in calling it erythroderma. It may evolve from xanthomatous drug reactions or from DRESS. The previous video I've discussed about DRESS, so which is drug reaction with eosinophilia and systemic symptoms. So, it may evolve from that as well. Epidemiology, it is seen in around 2 to 8% of all the cutaneous adverse drug reactions, and it is a cause of around 5 to 40% of all the erythrodermas that we know. The causes of erythrodermas can be your psoriasis can cause erythrodermas, and there are many other such causes which can cause erythroderma. So, this would be 5 to 40% cases of all the erythrodermas. Even dermatophytosis can cause erythroderma, right? Pathophysiology, it is characterized by there's increased epidermal cell turnover rate, there's decreased transit time, and there is increased mitotic activity. So the cells are dividing very fast here. The complex interactions of cytokines, chemokines, and adhesion molecules, the inflammatory markers, are also seen here. Both Th1 and Th2 type of cytokines are released here. There's upregulation of adhesion molecules like CD62 ligand on keratinocytes. So basically, there's an inflammation which is happening along with increased epidermal cell turnover rate, which is present here. Clinically, there's abrupt onset within days of intake of the drug. So within few days of the intake of the drug, there'll be abrupt onset of the lesions. Prolonged latency is seen only if it associated with DRESS. There's generalized scaling and erythema seen on the skin with pruritus, that is itching is also present. Constitutional symptoms like fever, myalgia, arthralgia, malaise, headache can also be present before the lesions arise. So the commonly involved drugs, commonly implicated drugs here are, as we all know, in any drug reaction which is anticonvulsants are implicated. So we have carbamazepine, phenytoin, phenobarbital present here, which can cause. Then we have allopurinol, then also cotrimoxazole, penicillin, cephalosporin, vancomycin, ATT drugs, antitubercular drugs, anti-HIV drugs, NSAIDs, acitretin, omeprazole, PPS, that is omeprazole, lansoprazole can cause. Calcium channel blockers, lithium, chlorpromazine, trazepam, imatinib, interferon alpha, heavy metals, and complementary medications also can cause. So mostly the things that you remember here are the anticonvulsants which are present here: allopurinol, antibiotics like clotrimazole, penicillin, cephalosporin, vancomycin, ATT, and ERT. You can remember, that is antiretroviral therapy, PPIs, and CCB's lithium. So, few important drugs you can remember which can cause this drug reaction. Differential diagnosis for this would be if there's any generalized exfoliative dermatitis by any other cause, then acute psoriasis, eczema, cutaneous T-cell lymphomas. So these are the differential diagnosis which presents with widespread erythema and scaling. Other diseases which can cause similar lesions are the differential diagnosis for this drug reaction. And then investigations, patch testing for the particular drug can be done, and routine blood investigations like CBC, LFT, RFT, also urine routine can be done, right? And CRP also can be done, which are inflammatory markers which tend to elevate in cases of drug reactions. Treatment, the most important treatment that we do here is to basically identify the drug and withdraw the drug. Stopping of the drug will help in reducing the lesions, right? So stopping the drug is very important. Otherwise, for the symptoms, you can give topical and systemic corticosteroids for a short course of time until the lesions resolve. You can give them. The most important thing is you have to stop the drug which the patient is taking, which is implicated here. Okay, so that's very important for the treatment. Complications, because there's widespread involvement of the skin barrier is lost, right? And the functions of the skin, various functions of the skin, the thermoregulation function of the skin is lost. So the skin has many functions, many important functions to play. So if that is compromised, then complications like hypothermia, fluid and electrolyte disturbances, high output cardiac failure, sepsis from impaired skin barrier, and a less important condition maybe post-inflammatory hyperpigmentation or hyperpigmentation it can heal with. So these are very important to deal with, and you have to take care of these, that these do not occur, and treat it promptly. It has the best prognosis if the drug is withdrawn, but if it is associated with DRESS, cutaneous reaction may persist for weeks despite drug withdrawal also. So if it is associated with DRESS, then for a prolonged time it will be present, but the best prognosis is to withdraw the drug.